Today's my topic of presentation is hospital-acquired infection, classification and organisms.
Welcome.
So we'll see the terminologies which is used for hospital-acquired infection, followed by definitions, then burden of hospital-acquired infection, followed by classification and organisms implicated. So we'll start with the terminologies. So hospital-acquired infection is synonymously used with the healthcare-associated infection and nosocomial infection. Worldwide, WHO uses nosocomial infection and CDC was using healthcare associated infection. Then finally, CDC has decided to absolute the two terminologies, which is healthcare associated infection and nosocomial infection. And now it is the only terminology which is used is hospital acquired infection. So what is hospital acquired infection? Infections acquired by in hospital by a patient admitted for the reason other than the infection, and the infection should not be present or incubating at the time of admission. It should appear at least 48 hours after the admission. It also includes the infections acquired in the hospital but symptoms appearing after discharge, and occupational infection among the staff of the healthcare facility like needle stick injuries transmitted infection are also included in the hospital acquired infection. So how to calculate the hospital acquired infection? If I is the total number of hospital infections and D is the total number of hospital discharge, including death. So the hospital acquired infection rate is calculated as I divided by D multiplied by 100. So what is the burden of hospital acquired infection? According to WHO, which published the studies from 55 studies and 14 countries, showed that the 7% of the patient in developed countries and 10% in the developing countries have acquired at least one hospital acquired infection during their stay, and mortality of that hospital acquired infection is around 10%. So the right side snapshot shows the number of patients which are developing the hospital acquired infection of the total patients admitted in the hospital. So in India, if you see, there are 1 in every 4 patients develop hospital acquired infection according to the WHO data. So what it causes? It actually increases the functional disability and stress to the patient and also to the family. It also causes increased length of stay. Average, it is around 8 days. Increased use of drugs, antimicrobial agent, isolation techniques, additional laboratories, and ultimately cost to the patient and family. So it also causes the spread of the nosocomial infection to the community, and severe cases may lead to the death. So risk factors for hospital acquired infection are immune status of the patient admitted to the healthcare facility, hospital environment itself, hospital organisms which are colonized, diagnostic or therapeutic infection and suits, transfusion practices in your ward, and poor hospital administration. These are the risk factors for hospital acquired infection. Now, what are the sources of infection? They can be endogenous or exogenous. Endogenous source means the patient's own flora is causing the hospital acquired infection after admitting to the ward or hospital. Exogenous source can be environmental source like air, water, food, or inanimate objects. Healthcare workers can be a source of transmission, and other patients also lead to the infections. Now, what are the organisms implicated in hospital acquired infection? They are escape pathogen. Can anybody tell what is escape pathogen? So escape pathogens are Enterococcus faecium, MRSA, Staph aureus basically, then Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter or E. coli. Now Enterobacteriaceae term is now obsolete. Enterobacterales is the terminology which is labeled by CDC for the is broad use. So if you go to the CDC website, it is the list showing the organisms which is causing hospital acquired infections. If you see the above organisms which I told, they are escape pathogens, but it also includes the Mycobacterium tuberculosis, norovirus in pediatric population, then hepatitis and HIV virus which can be caused by the needle stick injuries after admission to the ward. So this is the list of the hospital acquired infection. There can be a bloodborne infections like just I told you, hepatitis C virus and HIV. These are transmitted by blood transfusion, needle or sharp injuries or splash injuries. So what are the modes of hospital acquired infection pathogen? It can be a contact transmission divided into two, direct or indirect. It can be skin to skin. Indirect is like dressing, gloves, instrument, stethoscope, parenteral transmission through splash injury, saline flush, syringes, and vials. Second mode is the inhalational mode. Inhalational mode can be a droplet transmission or airborne transmission. If the particulate size is more than 5 mm, it is a droplet and it travels for the shorter distance, and it can cause bacterial meningitis, diphtheria, respiratory syncytial virus infection. Airborne transmission, if the particulate size is less than 5 micrometer, then it can cause Legionella, Mycobacterium tuberculosis, measles, and varicella viral infection. Third mode is the vector-borne infections. The mosquitoes in your hospital premises, flea, carrying the microorganism can cause the hospital-acquired infection. And the fourth is the common vehicles such as food, water, medication, device, and equipment-related hospital-acquired infection. So what's the process of hospital-acquired infection? Patient gets admitted to the healthcare facility. Then patient encounters the surfaces, equipment, devices that are contaminated, followed by patient is infected with that pathogen, and already compromised patient becomes more sicker with the hospital acquired infection. So what are the major types of hospital acquired infection? There are major 4 types of hospital acquired infection: catheter associated urinary tract infection, central line associated bloodstream infection, ventilator associated pneumonia, and surgical site infection. So firstly, we'll see the definition of the COTI. COTI is defined as presence of symptoms or signs compatible with UTI with no other identified source of infection along with the colony forming unit of more than 10 raised to 3. Or it can be defined as in a midstream voided urine specimen from a patient whose urethral, suprapubic or condom catheter has been removed within last 48 hours. So what are the risk factors for the COTI? They can be advanced age, female gender, severe underlying disease, or placement of urinary catheter for more than 48 hours. Most commonly, gram-negative rods are involved in the COTI. E. coli is the most common organism. Gram-positive bacteria can also cause UTI. Staph aureus and enterococci occasionally cause the COTI. Second is the CLABSI, which is central line associated bloodstream infection. It is defined as primary laboratory confirmed bacteremia or fungemia in a recognized pathogen, which was cultured from one or more percutaneous blood culture after 48 hours of vascular catheterization. So pathogen cultured from blood was not related to infection at another site. It is also included in the definition of CLABSI. With common skin commensals like diphtheroid, propionobacterium, coagulous negative staphylococci, and micrococci must be cultured from 2 or more blood culture on separate occasion. So what are the risk factors for CLABSI? Age like less than 1 year or more than 60 years, malnutrition, low immunity, severe underlying disease, loss of skin integrity, prolonged stay in ICU, and device related can be presence of central line multinomial, non-tolerant central line predisposed to the CLABSI, healthcare worker related poor infection control practices such as hand hygiene. So most commonly, cons and staph aureus are the causing CLABSI, and followed by gram-negative rods and fungal infections like Candida. So this is the picture from our hospital infection control committee newsletter. So just for the awareness to the residents, it is published every 6 monthly to 1 year, and your ward specific data is included in this newsletter. So this is the snapshot from the neonatology department, blood culture. So it shows the cons is the most commonly isolated blood culture, positive blood culture. Third is the ventilator associated pneumonia. VAP is new or progressive radiographic consolidation or infiltration with signs of inflammation and purulent respiratory secretion in a patient with mechanical ventilator for more than 48 hours. What are the risk factors for ventilator associated pneumonia? It can be a device related, patient related, or healthcare worker related. Device related like endotracheal intubation and prolonged ICU stay leading to the colonization of the multi-drug resistant organisms, aspiration of oropharyngeal flora due to various reasons such as semi-conscious state or supine position. So healthcare worker related like hand hygiene of the and poor infection control practices. So organisms implicated in the development of VAP are gram-negative rods like Acinetobacter species and Pseudomonas aeruginosa. Other gram-negative bacteria like Klebsiella and gram-positive bacteria occasionally cause the ventilator-associated pneumonia. Fourth is the surgical site infection. So it can develop at surgical site within how many days of surgery? Can anybody answer? Surgical site resident? 30 days. And if you read the second sentence, within dash days of prosthetic material is implanted at it is 90 days. So it is underreported because 50% of surgical site infection develop after the discharge. So surgical site infection are classified according to the level of infection where it is developed. So it can be a superficial. It develops at the level of superficial incision site like skin and subcutaneous level within 30 days of surgery. Deep surgical site infection can develop at the muscle and facial level within 30 days of surgeries, except the surgeries like breast, cardiac, CABG, craniotomy, pacemaker implantation, or peripheral vascular bypass and implant surgeries. Organ space surgical site infection is defined as it develops at level of organ space within 30 days for all the surgeries except implant surgeries as mentioned above. So organisms involved in the surgical site infection are surgical site wounds can be classified as clean, contaminated, or dirty. For clean wound, most common cause is Staph aureus, and for other types, endogenous flora like anaerobics or gram-negative bacilli in gastrointestinal surgeries. So risk factors for surgical site infection are advanced age, obesity, malnutrition, diabetes, infection at remote site that spread through bloodstream, preoperative shaving of the site, inappropriate timing of the prophylactic antimicrobial agent. Antimicrobial prophylaxis is usually given to prevent the seeding of the organisms on surgical site. Usually, it is given 1 hour prior to the incision along with the induction of anesthesia. For you can simply remember as the organisms which are antibiotics which cover gram-negative, it can be given within 60 minutes of incision, and for gram-positive coverage, you have to give it like 2 hours before the surgery, 120 minutes. So for audience, there is one question. So you have to calculate the hospital acquired infection rate, which I told you earlier in the first previous slide, the formula of the hospital acquired infection rate. So if you see over the period of 1 month, 90 patients admitted to the neurology ward, 10 patients developed hospital acquired infection, including VAP, surgical site, or bloodstream infection. 45 patients got discharged, 5 were dead, and 40 patients are still in ward. So what is the hospital acquired infection rate?
20 per 100.
So if you see 10 patients got infected and 45 got discharged. So 10 divided by 45 plus 5, including deaths, we have to calculate. So 10 divided by 50 into 100. So it is 20. Following are the sources I use for the above presentation. Thank you.